There's Iceman. Morning. So I forgot that today was MLK Day, so schools are closed and it's a federal holiday, and so I zipped to work in record time. So now I have like 45 minutes to be able to go live, so why not go live? So I'm going to start off with talking about fentanyl a little bit, because there's a video that's making its rounds right now on TikTok. That's the police, their own body cam video of the police officer in Florida who supposedly overdosed on fentanyl when wind blew it in her face, which is not a thing. But somebody mentioned to me that there was a case of two paramedics in British Columbia who had carfentanil exposure, and there was actually confirmed toxicological results of that toxicity. And so I did a little digging and learned that there was not toxicological confirmation, that they found trace amounts of opiates in their system, which does not refer to fentanyl, because back in 2016 when this was a case, or back in 2016 when this happened, there actually wasn't a way to have an assay test for fentanyl. And fentanyl is not an opiate, it's an opioid. And so what they would have found in their system would have been something like morphine or codeine or something like that. So that, if you ever hear somebody mention the British Columbia paramedics where they had confirmed carfentanil in their system, that's actually not true. I'm enjoying my last day of vacation. Oh man, enjoy it, man. Enjoy it. Man, there's just nothing like having that vacation, right? Do you work traumatic arrests where you work? We do not have, the region I work in is not very progressive when it comes to working traumatic arrests, and I think that most people will fall into one of two extremes, which is either trauma dead is trauma dead, which is not a thing, and if you believe that, you need to fix yourself, because survival rates in traumatic arrests are higher than they are in cardiac arrest. But then the other extreme is that rather than thinking about the hot mnemonic, which is hypovolemia, oxygenation, tension pneumo, and tamponade, and attempting to fix those things first, they treat it like a cardiac arrest, and they lead off with compressions, which often exacerbates the causes of traumatic arrest. So there is not a regional policy on how to approach traumatic arrest from a progressive standpoint. I'm sipping on Bonded JD right now. Oh, did you just come off a cruise? What's your policy on traumatic arrest where you work? Nah, just that 100 proof. Gotcha. I have a sentimental spot for Jack Daniels. It was the whiskey that obviously a lot of people get started on, and that's what I got started on. I hardly ever drink it anymore, because I'm just into much more quality whiskeys, but there's always a soft spot in my heart for Jack Daniels. Good morning, everyone that's joining. Good morning. You rocking the dome, bro, pulling off. Yeah, I mean, didn't really have a choice. I vowed to myself at a very young age that if I ever start seeing some shine there, that I wasn't going to try to fool anyone. And so I remember my mother took a picture of me holding my youngest child in a swimming pool, and she was, on the deck. And so it's from above, and I saw a tiny little bald spot there, and so I just shaved the very next day. Trauma codes and obvious death protocol can be a fine line. Yeah. I mean, if you respond to a call and the steering wheel is literally inside of the person's chest cavity. That's an injury incompatible with life. But you respond to a call and the guy is pulseless and apneic, but you don't see visible signs of trauma. That guy needs bilateral needle decompression or finger thoracostomy. They need pericardiocentesis. They need intubation, and they need volume replacement, preferably blood. And you may be able to save that person's life. Need creative ways to punish fire that get, yikes, that get dual dispatched to every job with entire engines. Job, you must be in New Jersey. As an EMTB, that's something I struggle with. I didn't get enough training on when to resuscitate. Well, when in doubt, resuscitate. I mean, if a person has suffered an injury incompatible with life and you attempt to resuscitate them, the worst that can happen is that they are, in the exact situation that they were before. So you definitely need to live by that rule. And even if just by chance, you happen to restore a pulse for some strange reason, but they have no neurological activity, the family can make a decision then, and, it certainly isn't going to feel any worse than, they're going to be dead either way, so the family, and maybe at the very least got a chance to say goodbye. But, yeah, services definitely need to do a better job of helping their personnel approach a traumatic arrest. Had a patient with high end tidal earlier tonight. My medic hyperventilated to lower it, and I was shocked when it worked so well. In what context did they have that high end tidal? Afternoon. You are my Irish friend, right? After 5 minutes of bagging, went to 50. Right. Again, in what context did they have high-end tidal? What was the call for? That's you, and I got it right. I said Irish. Are you an Irish whiskey fan? I find Irish whiskey to be a little bit too sweet for me. Oh, seizure patient, end tidal of 79. Were they post-ictal? What causes COPD patients to worsen when exposed to cold air? Got yelled at that as a new EMT. Because it causes their lung parenchyma to be more reactive. The lungs and all that tissue naturally does not want to get exposed to that cold air. And that can often be a trigger for asthmatics. What causes bronchospasm sometimes is sudden exposure to cold air. Asthmatics have very low triggers as far as what sets them off. But, cold causes a lot of things to spasm and constrict. And so cold air does that to the bronchioles and the alveoli. Good morning, EMS Avenger. Having my coffee with you this morning. Good morning, EMT girl. Enjoy your coffee. Would you rather only be able to take lung sounds through jackets or never put a Band-Aid after a BGL? I would rather never put a Band-Aid on after a BGL, which I never do that anyway. I give the patient a 4x4 and just ask them to hold that there for a second. Those things stop bleeding almost immediately unless they're on blood thinners or something. You're a lover of whiskey. Yeah, I'm a lover of whiskey too, but Irish whiskey is a little bit too sweet for me. And then in the U.S., something like Jameson is more like a party whiskey anyway. I caught the norovirus yesterday, threw up twice and passed out after each time of vomiting. The norovirus. Not the coronavirus, the norovirus. Can I get CEs for watching this chat? I wish that I had a means. I wish that I had a means of doing that. You'd actually be surprised in how often I get asked that. But there has to be some sort of means of determining that somebody has actually watched something, and then there has to be some sort of test. So I don't know how to do that. Yes, that is a medic mindset sticker. Ginger is a friend of mine. She sent me a couple of stickers. She's a mentor of mine, and we talk relatively regularly. People put Band-Aids on after a BGL. They do here. We have a tiered system here. The fire department gets to a call usually before we do, and they often get a finger stick, which is fine if it's diabetic related. I don't like getting finger sticks on people if they're not diabetic and the call has nothing to do with that. I think that you shouldn't be performing unnecessary painful procedures on people, but they always put a Band-Aid on. And, okay, sure, why not? I'm a bourbon girl. Well, you go with your bourbon. I also find bourbon to be a little bit on the sweeter side for me, but I do much better with bourbons. My favorite bourbon right now, not my favorite bourbon of all bourbons, but my favorite bourbon that I have in my collection is Metallica's Blackened Bourbon, which, before you laugh, is actually a very high quality bourbon. I really, really like it. Norovirus is the vomiting bug. Of all the bugs that I would like to avoid, it would be a vomiting bug. Man, do I hate vomiting. And anyone out there who's a responder who, gets mad at people for calling because of throwing up, when you're throwing up and you can't stop throwing up, you just lose all reason, and you will do anything to stop throwing up, and I don't blame people for calling 911. How do you feel about the National Registry as the minimum base level of training? Well, they're not really the base level of training. They set a standard that you have to achieve in order to be a nationally registered EMT or paramedic. But NHTSA sets the base level of training, the National Highway Transport and Safety Administration, and then there's specific curriculums that are, like Brady and that sort of thing, Limmer, that design their curriculum off of that. And most agencies and curriculums keep that in mind as far as training for the National Registry. But I do believe in the concept of the National Registry. There needs to be an acceptable standard of training across the U.S. Is that what you were getting at? What's your opinion on responding to calls non-emergent? Sometimes dispatch doesn't get it right. I think that we should be setting a target. I think that one study said that we should be setting it for less than 15% of calls should be responded to emergently. And I believe in that. Generally speaking, our level of response, how fast we get to a call, has nothing to do with how well that patient's going to do, except in specific situations. So somebody's not alert, somebody's not breathing, there's a cardiac arrest, somebody's reporting chest pain, somebody's experiencing respiratory distress. And when I say respiratory distress, I mean it's a respiratory distress call, not I fell and hurt my ankle. Okay, are you having any trouble breathing? Yeah, it's a little tight. That's not a respiratory distress call. But those are the calls that get bumped up to breathing difficulties because of the way we triage things. But I think we should be responding to most of our calls non-emergency. We shouldn't be trading one life to another. We've all been out there every day and seen the wrecks that happen because of what we're doing on the road. BGL is part of vital signs, though. No, it's not. No, it's not. You weren't taught that in school. Your vital signs are blood pressure, respiratory rate, heart rate, and temperature. Those are your vital signs. And I bet you that more paramedics than not don't get a temperature, whereas that blood sugar has almost nothing to do with most of your calls. Now, that doesn't mean that it's not prudent to get as many blood sugars as possible. And, if I'm going to, but I try to think about it pragmatically. Am I going to be getting a line? If I am, then I will get that blood sugar from the line. But if the call is for, let's say, a guy rolled his ankle, when he was running, and, there's no obvious deformity, and, the guy's not a terrible amount of pain when he's not putting weight on it, I may not get a line on that guy because I may not be providing anything for him, and that guy may go to triage with that leg elevated and wait there for 4 hours, in which case the line that I will establish will have almost no utility to the hospital at that point as far as draws go. So I'm not going to get a blood sugar to that guy. It has nothing to do with anything. I don't think blood glucose is at all part of vital signs. It's not. But it is relevant in altered mental status and diabetic-related stuff. Yes, absolutely. I mean, you tailor your assessment and your diagnostics to the chief complaint. I was an electrician for a long time, and obviously there was steps to troubleshooting electrical problems. Is this thing plugged in? Is the breaker turned on? Is the switch turned on? And when you went through those troubleshooting steps, if those easiest fixes in diagnostics fix the problem, you didn't tear the electrical system apart just to make sure it was something else. And we don't do that in healthcare either, because the whole thing falls apart when you start conducting yourself like that. So doing painful finger sticks on people who are not diabetics, who do not have calls where you can, with a reasonable certainty say it has nothing to do with their blood sugar levels, there's no reason to get a blood sugar. Look into Guardian CME for CEUs. Yeah, absolutely. And some of your states may have hundreds of hours of free CEUs. I'm in Georgia, and the Georgia Department of Health has hundreds and hundreds of free CEUs for responders in Georgia. Do you work in a multi-tier system, or is it just basic and paramedic? Well, we work in a system, at least in Cobb County, Georgia, where the fire department responds with a private service. And that fire department will have basics, and they'll have advanced EMTs, and they'll have paramedics. And the private service will also be an EMT/paramedic service. You'll have a paramedic, and mostly as the second person, it'll be an advanced EMT, but sometimes a basic. It'll be a basic, generally speaking, if they're kind of like a really standout basic, or they're in advanced school or in paramedic school. In Kentucky, you must be nationally registered to apply for initial application, which has been super frustrating. Huh. That's interesting. I can see I can see a state using the registry to certify people. That's interesting. What do you think is the most important quality for an aspiring medic? The most important, there's two things. The first is you have to be a curious person. You have to want to know what's going on with your patient. I see a lot of people sputter out after a couple of questions, and, I don't know if they're bored or they're just not interested, but they just don't dig and they don't pursue. And you are never going to be a good provider without that level of curiosity. And then the second is compassion. You have to be able to see and recognize and respect the innate value that every human life has. And if you don't possess that, you're going to start categorizing your patients as worthy of your care and unworthy of your care. And if that happens, you're eventually going to run into a situation where you dismissed a patient who had a legitimate chief complaint who deteriorated. Add blood sugar and pulse oximetry to that list. Those are diagnostics, but they're not vital signs. And, yeah. Hey now, feeling the forehead with the back of my hand totally counts as a temperature check. Right. I mean, but we all should be doing that, though. But let me just say, if you work for a service that doesn't have either oral temperatures or tympanic temperatures, then you might as well just not. I mean, if you're walking up with an infrared sensor and checking somebody's forehead, our fire department uses those, and we'll come in and they'll give me the descriptions of a UTI, but say the patient's temperature is 98.5, and I'll be like, okay, well, let's check it with our tympanic thermometer, and their temperature is like 103. Those probes that do like infrared, they're not checking a body's temperature, they're checking the skin's temperature. So that person is covered up with blankets in a room with a ceiling fan going, that's just blowing cool air on somebody's head. You're not getting an accurate temperature. You need, if you have a regular thermometer that you can do axillary or oral, or a tympanic, that is way, way better. EMT classes here have added BGL to mandatory vitals list. Okay, well, it's not a mandatory vital sign, and it shouldn't be. Follow your local protocols. I don't think that is part of the national standard, though. So if your local EMT class is teaching that, I question whether or not that's actually in your curriculum or whether that's just your instructor teaching that. I'm not saying it's not, but I would like to see the citation for that. In fact, there's a little bit of a movement going on and some pushback against that being a thing. If anyone is familiar with Brian Bledsoe, everyone who is now working as an EMT or a paramedic has been educated in some way by Brian Bledsoe, because he contributes to most of the national curriculums. And he's on record saying that we should stop doing needless finger sticks on people. Shouldn't blood glucose really be a specific diagnostic tool depending on the situation? Yes. Illinois no longer has a state test. It's national registry. Most states use the registry. There's only a few that don't. I broke my femur and the medics helped me get to the hospital under immense pain. Did they relieve your pain? Any healthcare personnel should practice humility. Yes, but any human being, right? It's okay to not know something, not okay to fake it. That's true. Hey man, hope you're well. I am well, and I hope you are too. Did you just get on your shift, or are you headed off? I am going to be clocking in about 25 minutes. I give myself a lot of time to get to work because I live in an area with a lot of traffic, but I forgot that today's a federal holiday and there was no traffic whatsoever. Do you work for a 911 service or medical transport? I work for a 911 service. That's all I want to do. I would die doing like BLS interfacility. Now, I often do critical care transports between facilities, and those are fun. In fact, if I could get on a truck somewhere where I was doing nothing but critical care, not like run event call and then take a person from the hospital back to a nursing home, but all day critical care, I would love that. The scope in my county is so much less than the national registry, but the next county south is max scope. I've seen that, and I worked in regions where that is, where one service just doesn't do a whole lot, and the next service, their protocols are freaking amazing. Glucose isn't a benign procedure. There are risks. I mean, they're low, but we shouldn't be inflicting pain on patients when we don't have to. And the thing is that we take advantage of patients in this regard sometimes when we perform procedures that we don't need to perform, in that they may not protest it, but they may not understand that they can protest it. This discussion was happening a little bit on another one of my videos in regards to 12 leads. Someone made a comment about a partner who performed 12 leads or wanted to do a 12 lead on someone with hip pain. And my response was, if they wanted to do that and the patient consented, then I would encourage it, because people who are newer to 12 leads, the thing they really need to see is a lot of 12 leads on people that don't have cardiac complaints, so they can see how abnormal a lot of people's 12 leads really are, but it's just basically an abnormality that doesn't affect their everyday life, and they need to be able to filter that out when they're looking at a 12 lead in someone that has a compelling story, so they don't mistake it for something diagnostic. And then there's a lot of talk about you should just do 12 leads on everyone, and that can be a very, very inappropriate procedure. You get some young female with a double male crew, and she has a complaint that's not a cardiac complaint. That is a very inappropriate thing to do to that patient, which is to subject them to a 12 lead. And you know what? That patient may not even realize that they're being taken advantage of, or that they're being put in a situation where something is being done to them that didn't need to be done. They're trusting that crew that they know what they're doing. And that shouldn't even apply to a young female. It should apply to any human being that is having their modesty compromised. That patient needs to be informed as to whether or not this procedure is necessary. And if a blood glucose is not necessary, if it doesn't relate to their chief complaint, that patient should be informed that they have a right to say no to a painful yet non-informative procedure. Here's a good one. How do you deal with partners who are difficult to work with? In most cases, I try to take one for the team. I often get partners who are I'm their last rung on the ladder. My company has said, this partner has churned through multiple partners, and we need to have them with someone who will be patient with them if that's what that person needs, or will be specifically not patient with them, because sometimes someone needs to be put with a partner that has no patience for their nonsense. And I tried to take one for the team in that regard. Like a couple of years ago, I was given a partner who didn't get along with anyone. And she got into EMS late in life. She was in her 60s. She had like a year and a half before she retired, and she was very difficult to work with. Very set in her ways. She interfered with the paramedics on calls, trying to give holistic advice to patients. And it was terrible. Then they put her with me, and I just determined that I was going to let her ride into the sunset, no matter how much of a pain in the ass she was. But I've also worked with a partner that, I've hated working with them. And I have so much patience for people. I really do. I'm committed to, when I'm given a partner that's a problem, to being infinitely patient with them so that they can get it right. But there have been partners where I simply have just drawn the line and told my company, not only are they difficult to work with, but they're making it so they don't want to come to work in the morning, and I'm thinking about a change if it doesn't change. And but the first question that's always asked when you complain to management about a partner is this a you problem or a them problem? So if it's a you problem, it really means, is it a personality conflict? Is the personality conflict in that you just don't get along with them? Like you don't like the way they look, you don't like the way they act, they have strange idiosyncrasies or mannerisms that you personally just don't like? Or is it that they do things that are intolerable to anyone, and you really have to ask yourself that at that point? And it's not management's job to resolve when you simply don't have the patience for a partner. It's their job to resolve. Sometimes there are irreconcilable differences, and at that point it's time for them to step in. But the onus really is on you to do everything possible to make that work first. And, the thing that we never do, that people rarely do because they don't like conflict, is to actually talk it out with a partner. And I recommend people read the book Crucial Conversations. The book Crucial Conversations teaches people how to have discussions with people, and healthy discussions with people. Because what we often do in conversations with other people is we assign them the role of the villain, and we assign ourselves the role of the victim, And life really isn't that way. You're just a person doing your thing in life, and your partner is just a thing doing their thing in life, and they don't have malicious intentions, and you are not better than everyone else, and you're not better than them, and I'm speaking in the generic sense. And trying to resolve that issue, making it not a hero versus villain situation, also helps facilitate those discussions. What are your thoughts on the 2 EMTs that are charged with murder? They needed to be charged with murder. That was a horrific thing to watch. It was clear that them doing that was not the first time that they did it. You look at the process they set up for that. That was a very rehearsed and practiced and polished process that they've done many times. And that is also clearly something that the service they work in is probably something that they've been turning a blind eye to. And it's just horrible, and they needed to be charged with murder. Patient's dignity should be maintained at all times, even doing a 12 lead. That's true, but their dignity needs to be preserved by recognizing when a 12 lead does not need to be performed. Medics who are overly eager to apply 12 leads on females are questionable. Yeah, I am really bothered by sometimes the way we conduct 12 leads on females, and in the way we just place electrodes on females. Like, I will generally at least do basic cardiac monitoring on most of my patients. So, that means just putting on the limb leads. And I cannot tell you how many times I have seen other responders, when all we're doing is rhythm monitoring, there's no 12 lead happening, they take the arm leads on a female and they pull the shirt down and they go like this to place them. And I'm like, she's wearing a tank top. Why are you doing that? And so, I always ask myself, is this necessary? And then I have rules for performing 12 leads on females, which is you never touch the skin with anything but the back of your hand. You obviously never cup. You always push things with the back of your hand. Obviously, you wear gloves. And what I like to do is, when I'm putting the leads 3, 4, 5, and 6 on, I always leave their shirt on, and I pull the shirt up, and I use the shirt to move the bra strap. I don't pull the shirt up. I don't pull the bra off. I just move things around, and I can, generally speaking, get a 12 lead on a female without any exposure whatsoever. And it should be something that's practiced, just like we practice a code, is placing a 12 lead on people while preserving their dignity. Seems weird. Is there any reason you can think of to support this? I'm not keeping... I've kind of lost track on what you're referring to. Practice mediation skills and therapeutic communication skills helps with conflicts everywhere. Absolutely. And sometimes you do need to sit down with a third party and just hash it out. My favorite therapeutic conversation rule: never ask why. Why is confrontational to people. I can see that. Vital signs right out of emergency care and transportation of the sick and injured, Chapter 10. Okay, then. Well, you need to know that to pass your test. You don't need to perform blood glucose on every person. I'm not saying that you can place 12 leads using the back of my hand. I'm saying that I don't move anatomy with anything other than the back of my hand. Thoughts on medic school being longer? Well, if it's not a degree program, it's not going to be longer. And if it's going to be longer, it should be a degree program. So the question really should be, should all medic programs be degree programs? And the answer is eventually. SpO2 and glucose listed as vital signs. That's what we teach. That's great that you teach that. And obviously you should be getting pulse oximetry on every patient, because it's not a painful procedure. It's immediately informative. Just make sure that you are checking a pulse. If you're not doing cardiac monitoring, that you're matching up a pulse. You should be getting a pulse on every patient. But blood glucose should not be done empirically. It should just not. Got about 5-6 more minutes here. Thinking about going into paramedic school and very, very nervous. Any advice? I think that what you need to remember is that you are not expected to be a paramedic tomorrow. You are expected to be able to pass a paramedic exam at the end of class. And even then, you're not expected to be a field competent paramedic after that, though some services will put you in that position. But you are expected to go and precept in the field at that point and kind of learn how it's done. So, the ancient wisdom of how do you eat an elephant, one bite at a time. And so don't be nervous, because you don't have to, even though sometimes it's going to feel like drinking from a fire hose, you're really just going to be given one morsel at a time, and you just have to worry about that one morsel at a time. But if you want to make it easy on yourself, get ahead of your reading right now. Do as much reading as you can right now. You don't have to cram or study, just read the material. Like, read your textbook. And then get one more read of the specific chapter you're going to have a class on before that class. And then after that class, before the test, get a third read where you take a highlighter and you just separate thoughts out. Again, you don't have to cram or study. You just break things up with a highlighter. You're going to thank me for that. You're going to send me a bottle of whiskey in the mail for that advice. Hey from North Carolina. Hey, back to you. I worked in North Carolina for 5 years in Brunswick County. Hi, do you think that those Illinois medics deserve 20 to 60 years in prison? Let's say you're not in EMS, and that was your dad or your brother or your best friend, and you called EMS because he was at the end of his rope and he didn't know how to help himself, and so he called this phone number, 911, and his expectations in calling that phone number was people were going to come out in a situation where he didn't know how to help himself anymore. And not only that, but from a mental capacity, he lacked the ability to help himself. And what he was relying on was people that could see that he was in need and that had compassion for him and recognized his innate value as a human being. And he expected to be treated with kindness and dignity and to be thrown a lifeline where somebody else could help him because he now could not help himself. And where he could see that if somebody else could just help him, that he still had some potential beyond that to contribute to society and to receive the benefits of society and to be a bright light to his children, to his siblings, to his parents, to bring joy to other people, to receive joy from other people, and enjoy all the fruits of being alive that other people enjoy. And instead of that, 2 people showed up and fucking restrained him to a stretcher prone and killed him. What do you think? So the answer is yes, I do. I do believe that. This is different from like the nurse, Redonda, I don't remember the last name, but who had the medication error where she didn't pay attention, and that patient got vecuronium instead of Versed. I don't believe that she deserved to be charged with murder. I don't believe that she deserved to have criminal charges at all as part of a just culture. But this is leagues and leagues and leagues beyond that. Thoughts on lidocaine as an antiarrhythmic? My unit has been using it more often for refractory VTAC. Well, you're talking about in cardiac arrest, I'm assuming, not in pulseless VTAC, or excuse me, VTAC with a pulse. There is no body of evidence that supports, that demonstrates higher survival rates with either lidocaine or amiodarone. And especially later in the code, it really, really shows no utility whatsoever. And there's also no body of evidence that demonstrates lidocaine or amiodarone as being superior to one another. There's just no evidence for it. There are some studies that have shown a benefit, a lot more that show no benefit. So when I say body of evidence, that we just don't have consistent evidence that it benefits the patient. If you have refractory VFib or VTAC, you are much better off doing a vector change, meaning you're changing the position of the pads. First, checking to make sure that from one pad to the other, that you're literally going over the medius part of the left ventricle. And then making sure that they're actually stuck really, really well to the patient. And then after that, possibly changing your position with a new set of pads to anterior-posterior. You will probably have much greater success doing a vector change than you will using an antiarrhythmic. Friends abroad is 100% a skill. I don't know what that means. How do you separate work mindset from life mindset? I do a pretty good job when at the end of my 3-day, I do 3 days in a row. At the end of my third day when I get home, I'm pretty ready for home mindset. And my girlfriend does a good job of letting me know when my mindset is not at home. You know, because obviously being a creator on TikTok, I'm thinking about those things all the time. And medicine tends to be a hobby of mine as well. I'm very interested in medicine. But I do have outside interests. You know, I've got, family in the area and friends, and we like to go out and do stuff. I love to hike and do things that are kind of rugged and outdoorish. And I like working in my garage and building and fixing things and doing things in the house. So the best way to separate your work mindset from your life mindset is have a hobby that involves motion and movement and getting out of the house. That is the best way to do that. If your hobbies involve playing PlayStation, or something that is very, very passive, it's going to be very, very difficult to keep work at bay. And also having a schedule that supports that as well. If you're on something like 24/48s, it's very difficult to do that because your first day off is kind of recovery from work, and your second day off is your preparation for work. And so you are almost never out of a work mindset. Having a schedule where you have days off, where you didn't work the day before and you didn't work the day after, is pretty necessary. There's a lot of messages piling up. I actually have to go in and clock in. So I'm really sorry for not getting to all these questions. But if you guys really want these answered and you really want me to answer them, please use my Q&A. And if I have some time and I really feel strongly about it, and I think it'll benefit a lot of people, I'll make a video. But I really appreciate everyone that follows me, and I really appreciate everyone that participates in these lives. I think it's really beneficial. I get a lot out of it, and I hope you do. And so everyone be safe. Appreciate all of you.